So Dr. Welton was one of our fellows last year and just had a baby. You look fabulous. Can't believe you just had a baby. So come on up. Tell us about complications in cartilage surgery.
All right. So my name's Linnea Welton, and the title of my talk today is Common Complications in Knee Cartilage Surgery. And thank you, Dr. McCarty, for inviting me to talk today at your symposium. So, my goal over the next 10 minutes is to give you a brief case-based review of the common complications associated with 4 of the most common surgical techniques for treating focal articular cartilage defects of the knee. Those 4 techniques will be microfracture, autologous chondrocyte implantation, osteochondral autograft, and osteochondral allograft transplant. Through these cases, we'll look at how the complication was recognized, how it was addressed, and maybe a little bit about how it can be avoided. These cases should also give you a broad categorization of how these complications can be grouped into 3 main facets, those being technical factors, patient-specific factors, and coexisting pathology such as meniscal injury, malalignment, and ligamentous instability. So our microfracture case begins with a 44-year-old female who presented to clinic with left knee pain after being involved in an airplane crash. She had an MRI which showed a 1.9 centimeter squared focal cartilage defect in the medial femoral condyle. She had tried physical therapy but remained symptomatic, and so she was offered an arthroscopic microfracture procedure. These are her intraoperative photos, and there was no other noted pathology during the diagnostic portion of this scope. Postoperatively, she was non-weight bearing for 6 weeks. She began immediate use of a CPM, and when she initiated weight bearing, we put her into a medial unloader brace. Unfortunately, at 6 months out, she remained symptomatic over the anteromedial joint line. So, a MRI was obtained at this time and showed that the area where we had microfractured did not have any infill, did not reconstitute with fibrocartilage. So at that time, we gave her some options, both non-operative and operative, such as a cartilage restorative procedure like ACI versus getting a second opinion. Now her decision, we will hold off on just a minute in terms of where she went from there and talk a little bit about the complications. So this patient experienced from microfracture poor defect filling. And poor defect filling can come from both technical and patient-specific factors. From a patient-specific standpoint, she was a little bit on the older side. From a technical standpoint, we try and look at how deep the microfracture and how far apart the microfracture holes were placed. Can you guys still hear me? Okay, there we go. What we try and do to make sure that we do get an appropriate infill is oftentimes during the surgery, we'll turn off the water inflow and keep the scope into the camera intra-articular so that we can see that there is blood and marrow extravasating from those microfracture holes, but nothing is a guarantee. Some other common complications are osseous overgrowth and subchondral fracture. So picking up where we left off with this patient brings us to our next surgical technique, which is autologous chondrocyte implantation. So again, she was 6 months out. She didn't have fibrocartilage fill of this cartilage defect, and she decided she'd try physical therapy again, but ultimately at 18 months out from her index surgery, she did have ACI. And these are the intraoperative photos showing the periosteal patch placed at the time of surgery. And she did pretty well at 1 year out. She could do all of her activities of daily living. However, some of her higher impact activities like running and soccer, she still remained a little bit symptomatic. We got a postoperative MRI at this point, which now showed that she did have decent infill, but it wasn't full thickness, especially on the most medial aspect. So again, we counseled her on operative and non-operative options, and she chose to not proceed with any further surgical intervention at this time. So in this situation, when she had her ACI, she experienced the complication of insufficient regenerative cartilage. And again, there are both patient-specific and technical factors associated with this. From a patient standpoint, age, again, is a risk factor, older age. And from a technical standpoint, periosteal patch and actually matrix-associated ACIs also has a higher rate of insufficient regenerative cartilage. Now, another complication, which is graft hypertrophy, which is actually the most common complication in ACI, also has patient and technical factors. And in this regard, periosteal patch also increases the risk of graft hypertrophy, but counter to the insufficient regenerative cartilage, it's younger patients that will actually have a higher risk of graft hypertrophy. Other common complications are disturbed and inadequate fusion and delamination. So moving on to our Oates case, we have a 24-year-old female who had 1 year of about superlateral knee pain. She was previously a Division I collegiate gymnast. At the age of 19, she had a dismounting injury and she sustained a lateral meniscus tear along with a small focal lateral femoral condylar lesion. At that time, her team surgeon performed a partial lateral meniscectomy and a microfracture. Unfortunately, again, her cartilage did not infill, and so she remained with persisting lateral knee pain. She went to a second surgeon for another opinion, who ultimately performed a 2-plug Oates procedure, and she recovered well from this. She was able to complete her competitive collegiate gymnastics career. But now she's 2 years out from graduating. She's working as a gymnastics coach, and she's having crepitance and pain over that supralateral aspect of her knee, especially with going downhill and sitting for long periods of time. Examination definitely corroborated that, and she was tender over the area where she had her prior donor sites from her Oates. So an MRI was obtained, and it did show that the supralateral aspect where her donor's sites came from had some incongruity and hypertrophy of that cartilage surface. Her Oat grafts, however, were very congruous with the cartilage surface and seemed to have incorporated well. So with her symptoms in mind and her MRI, it was felt that it was most likely donor site morbidity that was causing her pain. So she was offered an arthroscopic debridement, and here are her intraoperative photos. And she did very well post-operatively. She's returned to all of her athletic extracurricular activities. So donor site morbidity is the complication that she experienced, and this is the most common complication in Oates and mosaioplasty procedures. And this has to do somewhat with technical factors, but really it's also inherent in the biologic nature of taking an Oates, because you have to take the graft from somewhere, so there will always be a donor site. However, we do know that the larger the grafts you take and the more grafts you take, the greater the chance of having donor site morbidity. Another common complication is donor to recipient mismatch, and this has to do if the harvested graft is not congruous with the articular surface of the defect. So finally, graft fracture, chondral injury, and hemarthrosis are other common complications. And our final case now, with relation to osteochondral allograft transplant, deals with a 29-year-old male rugby player who presented to clinic with a history of 3 prior right knee surgeries, a microfracture, partial meniscectomy, and an osteochondral allograft. And approximately 10 months out from his OCA, he noticed a significant decline in his functional status. He was having new knee pain and recurrent effusions. So MRI was obtained, which showed that his OCA had basically completely deteriorated, and he was left with a approximately 4 centimeter squared osteochondral defect. Long alignment films were taken in clinic, and it showed that his knee was in a pretty significant amount of varus, and his weight-bearing axis was sort of right in the center of the medial compartment. So all this taken into consideration, it was felt that most likely his OCA had failed because of graft overload, because of his malalignment. As such, he was offered an opening wedge valgus-producing HTO and a revision OCA. And that's what he had done. Here are some of the intraoperative photos. He's about a year out. He's running, he's weightlifting, and so far he's very happy with where he's at. So graft overload was a complication he experienced from his first OCA. And this is commonly due to an issue of malalignment. Another common cause of graft overload is an incongruous, basically an incongruous graft, which you can also see with oats. And that can either be because it's not, the surface doesn't correlate well with the donor site that you need it to go into, or it can be placed a little bit incorrectly. And so that can also lead to graft overload. Other common complications are allograft fragmentation, early loosening, and subchondral collapse non-union. So in summary, there's certainly no single technique that is superior or that will treat all cartilage defects of the knee. I think it's also important to really know that common complications can be both shared and also unique depending upon the cartilage technique that you're using. And that's important to know as we are making our decisions and also as we are educating our patients about the options. With regards to clinical workup, it's important to know about the characteristics of their symptoms and also their prior surgical history. From an imaging standpoint, in addition to standard knee series, getting an MRI and long alignment films are important. And finally, I think the complications are certainly varied and multifactorial, but they can broadly be grouped into three main categories, those being technical factors, coexisting pathologies, and patient-specific factors. All right, thank you, and happy fall.